Assalamu alaikum. My name is Dr. Mohammad Fazlur Rahman, and today we are going to talk about nerve injuries and nerve transfers. When we have a nerve injuries, we have several options, which is nerve repair, nerve graft, nerve transfer, and tendon transfer. So the question arises, why do we need to do a nerve transfer? What is a nerve transfer? Nerve transfer means that if you have a nerve which is injured and the part which is injured is very distant from the target organ, and if you think you'll repair the nerve, there will not be enough time for the nerve to regrow and reach the target organ in 18 months. You take a part from another nerve which is near the target organ and give that part of the nerve of another nerve to this damaged nerve. And this will help in quicker regeneration and return to function. So basically, what you're doing is you're changing a high injury to a low injury. Where you had a nerve, let's see median nerve, it was injured high in the axilla and it has to supply the thumb and it cannot regenerate in time. So you take a part from one of the other nerves near the thumb and you give that part from another nerve to the median nerve motor branch, which you want to reinnervate. This you are converting a high injury into a low injury. But this helps in decreasing the distance between the nerve repair and the target organ. When should you operate? Well, if it's a traction injury, it's a closed injury, you think there might be neuropraxia, in that case, you can wait for 3 months. Otherwise, if you think it's an open injury and it needs to be treated earlier, you should go in and do surgery sooner. What are the indications of doing a nerve transfers? First of all, these nerve transfers were made for brachial plexus injuries, where you did not have any graftable proximal nerve, or where you thought the distance was too far and the injury was in the neck, you had to supply the arm. So these transfers were made the brachial plexus injuries. Then for any high proximal injury, which we talked about, then if you think you can repair the nerve or do a nerve graft, but the nerve is going to pass through an area which is totally scarred, and there might not be regeneration in that area with pure vascular supply, then you should do a nerve transfer. Or if you think there are going to be a major grafts required and there's some major limb trauma, you can do a nerve transfer. Or if that's a partial nerve injury with definitive functional loss and you think that doing a nerve transfer is better, you can do it. What are the principles of nerve transfer? The principles of nerve transfers are very similar to the principles of tendon transfer, which is that just like a tendon that is used should be expendable, the nerve used should be expendable. Then the motor nerve should be used for motor nerve, sensory nerve should be used for sensory nerve. The distance for the nerve should be short. It should have a similar cross-sectional area, just like as we say in the tendon transfer that it should be a similar tendon, similar size. There should be synergistic muscle innervation, just like a tendon transfer. We say it should be the synergy between the tendons, and you should be able to save your tendons for potential tendon transfers. What are the advantages of nerve transfers over tendon transfer? First of all, it's a more physiological repair. So the retraining in the brain is usually easier. There's no prolonged immobilization, unlike a tendon transfer. It can be done in stiff hands, and in case of radial nerve injury, you can get independent finger movements. However, the tendon transfers take longer to occur. If you have so the nerve transfers take longer to the results to come back. So if you have a tendon transfer, you do a tendon transfer, you put a cast for 6 weeks, you take off the cast, there will be some movement. But when you take a nerve transfer, when you do a nerve transfer, the result will not come back as soon, but it will take more 6 to 9 months to come back. And what are the contraindications? If you think that some other method is better, has less morbidity, maybe you can do the primary nerve repair. It's close to the target organ, so the nerve transfer would be better. Some other method would be better. If you think that there's a nerve injury which is close to the distal site and you can repair a graft, it's going to be better. If you think it's axonomatosis or neuropraxia, you should leave it. And if it's more than 6 months of injury, you should not be doing a nerve transfer. What we don't know is what are the actual numbers of axons that are required for nerve transfers and what is the time limit. I mean, we talk about 6 months, but there are people who say they do nerve transfer up to 9 months or even 12 months. So we don't know the exact time period for nerve transfers. Where do we use these nerve transfers? We commonly use it for the suprascapular nerve injury, and we use the spinal accessory nerve, the musculocutaneous nerve injury, we use the branch of median ulnar nerve. For axillary nerve injury, we use radial nerve branches. For radial nerve injury, we use the branches from the median nerve, FDS and FCR. And for ulnar nerve injuries, we use the anterior interosseous nerve. Thank you.